Well, Charles, thank you. I'm so glad to be having this conversation with you. And I'm sorry I'm not able to be there at the summit this year, which I know is bigger and better. So, congratulations. Um, in part because I'm at the UK HSA conference, which is in Manchester at the same time. So, I'll be doing a number of sessions, presentations in Manchester at the UK HSA conference. But I know that this year's summit is going to be amazing, and I'm so glad to have the time to have this conversation with you. And yes, I remember last year those words: when we know better, we must do better. And that those words have been really important to me in my own public health practice because it says that the process of learning and developing is not just an intellectual or individual pursuit, but that process of growth, learning, and development must be in the pursuit of doing better for others. And that's particularly so in our public health practice. So last year, we reflected on the knowledge and experience that we developed through the COVID-19 pandemic should encourage us to do better, not only for COVID-19, but for chronic diseases, for infectious diseases, for social conditions, because we learned so much in the pandemic. This year, I would argue that over the past year, we've seen examples where we're now doing better. We have articulated the challenges of Black maternal mortality and morbidity, and we now have a range of research and programs which are being done and implemented to help us to address and to understand why Black women are 3 to 4 times more likely to die during their pregnancy and childbirth, and what we might do to improve that. Over the past year, the focus on doing better for patients with sickle cell disease and thalassemia has led to a number of programs within the NHS, and you can see the benefits of those programs in improved quality of life and outcomes for those patients. And I'm really excited. In the last year, we've seen the focus on Black men and prostate cancer, again, as a result of advocacy, data, where we're now seeing more programs available to educate and empower Black men about earlier diagnosis and earlier care for prostate cancer. Now, those are just 3 examples where when we know better, we can do better and we must do better. And what I'm keen to see at this summit is that of the hundreds of participants who are attending, that they're inspired by the talks, the research, the policy papers that are going to be presented and discussed. And they will ask themselves, each of us, how am I going to do better as a result of attending this summit? And what behaviors will I change to have more impact when I return home? And that, at its core, is what knowing better and doing better is. I would be reflecting on just how fantastic the initial summit was. It was a real moment in time to bring us together to celebrate Black excellence, to hear from amazing speakers, and to inspire people from all walks of life in different phases of their careers around the importance of focusing on Black health and to share some of the great work which is being done. And I loved the fellowship that was at the summit last year. And it was so wonderful to meet so many old friends, new colleagues, to see the next generation of researchers who were there too. And that sense of camaraderie, of the spirit of can do, was so important at last year's summit. So I'm excited to hear about what will happen at this year's summit. Data is king, and data remains king, Charles, because it is the foundation for understanding not only the populations that we're serving and the characteristics of our populations and the needs our populations have, but data are also important in understanding the interventions which can help us to tackle those health needs as well. Data helps us to evaluate the effectiveness of the interventions that we're putting in place, and data also helps us to understand or progress towards meeting our targets. At our summit last year, I argued for, and many of the presenters argued for, better ethnicity data collection in order to characterize ethnic and racial differences. But also we need to understand the context within which our ethnic minority communities reside, live, and experience lives. So understanding economic realities, housing realities, educational and employment opportunities. So we have a more holistic picture, not just the health outcomes. So Are we doing better? I think we continue to be on that journey. In the NHS, there has been tremendous advances made in population health data, new platforms which are enabling us to understand diseases, how they're patterned within communities, and how they affect different communities. And we're using that population health data to target our activities better. And we're also seeing the use of better public health data to help us to understand the impact that we're having on population health. There's much more that we can do and much further that we can do. And I think our collective efforts and at this summit to have that focus on improving data and insights and how we use those data will be a critical discussion point at this summit. We have long argued, certainly in my role in the president of the Faculty of Public Health and as a director of public health, that racism is a public health issue, in part because of the pervasive nature of it and the impacts that racism has on the health, well-being, economic productivity, and life chances of individuals within our society. We continue, both in my work as Regional Director for London, working with our partners and health and care leaders in London to keep a focus on structural racism and the things that we can do across the health and care system in London to tackle structural racism. And I'm really pleased over the last year that we have, through our partnership with the GLA and the NHS and local government in London, been able to fund both the work of Professor Sir Michael Marmot to look at the impact of structural racism in London, one of a major report from the Institute of Health Equity, which really shines a light on the nature of structural racism and its impact on the health and well-being of Londoners. We've also funded the London Anti-Racism Collaboration on Health Project, LARCH, which really is bringing together our partners across London who are involved in anti-racism approaches to share best and promising practice and to ensure we have consistent approaches for how we discuss anti-racism and how we implement programs within the health and care system on this issue. And as you remember at last year's summit, I introduced London's strategy on anti-racism in the health and care system, and that also is being implemented by our ICSs. I'm really excited, Charles, because in the last couple of years, we've appointed Dame Marie Gabriel as our anti-racism champion for the health and care system in London. And she, along with other leaders in the NHS, have been doing phenomenal work looking at data within the NHS on structural racism, training and capacity building of NHS managers and leaders, advocacy with our staff around anti-racism and tackling inequalities, and looking at data within the health and care system on experiences of bullying and harassment, racism and discrimination of NHS staff. So over the past year, not only have we been through LARCH looking at how we build capacity in our partners, but at the same time, our NHS leaders have been implementing their own strategies on anti-racism as well. So I guess my summary of this is, yes, we can. Yes, we can develop the strategies that help us to focus on anti-racism in a much more structured way. Yes, we can look at systems and organizations and develop plans, strategies, and actions that can make a difference. And yes, we can use the data that we have from our staff survey to ensure that the lived experiences of our staff related to structural racism is actually improving, and where it's not, to take corrective action. I think this structured approach is something that we can all learn from, and I'm keen to learn from other regions which are also doing work in this space. Some of our colleagues who haven't heard about Million Hearts and Minds, it's a new pan-London regional initiative on cardiovascular disease prevention. We are developing this new pan-London program to run over a 5-year period, because we recognize that as we've exited the COVID-19 pandemic, that heart disease and death and morbidity from heart disease remains among the top health priorities for Londoners, resulting in premature mortality and people falling out of work because of ill health. So we wanted to build upon a lot of fantastic local work which is being done on CVD prevention, but to give it that focus and that prioritization as a regional priority through this new Pan-London program. So it's called Million Hearts and Minds because we want to engage 1 million hearts and minds across the city on better heart health. And you're absolutely right. We are building in community engagement and mobilization throughout that program. Again, because when we know better, we do better. We did this in COVID with the vaccination program. We did it subsequently with the London vaccine and equity programs, where we worked with so many community organizations. And for 1 million Hearts and Minds, we want to bring that community assets, those assets, that engagement and the lessons learned to helping and working with communities to tackle and improve heart health. So over the next 5 years, the plan is that investments from the NHS and local government will be combined with and used to leverage resources from voluntary, charitable, and other funding sources to build a prevention pot that helps us to pilot new ways to support cardiovascular disease prevention and control, and to fund innovative programs where we can engage communities and support community-driven activities. This is so critical, Charles, because we know that CVD, cardiovascular disease, isn't randomly distributed across our region. We know that the economically deprived parts of the city have higher rates of heart disease, uncontrolled blood pressure, and stroke. And we know that especially for men, Black men and men of Asian backgrounds have some of the highest rates of cardiovascular disease across the city. And we need to do a lot better of engaging them, linking them to care, and helping to activate members of the public on their heart health. So we're at a very early stage in the program. We've just finished our first year, which is our foundational year. We're building the architecture for this new Pan-London program, but I'm so excited that communities are at the heart of 1 million Hearts and Minds, and we look forward to sharing the results of this program at further summits as we progress.